Assalamu alaikum wa rahmatullah. Good evening, everyone, and welcome to our new format. On behalf of the Neonatal Multispecialty team, I would like to welcome you to this new format that we started this month. This will be our first episode. This will be the Neonatal Multispecialty Grand Round, and let me just brief you about, for those of you not familiar with the Grand Round, what is the meaning of it. Let me just brief you how the dynamic of this episode will go. The Grand Round, it's actually based on case presentation. So we select an interesting case, and then we're going to present this case, and then we'll have comments on the case. So tonight's case was selected based on the several cases that was sent for me in the last month. The case presentation tonight will be by, it's a case actually from Egypt. This will be by Dr. Naima. Dr. Naima Hamouda. She's a neonatology registrar. She's working in Egypt in Al Sahel Teaching Hospital. She has MRCP-CH from UK, and she's currently a fellow of the Egyptian board, neonatal board. She has more than 10 years experience in the neonatology. I have been contacting Dr. Naima for the last months to prepare for this case, and as I said, hopefully it's going to be an interesting case for you. Dr. Naima first will present the case, and then we will give you a chance to ask further questions. If you need any clarification or any more elaboration from Dr. Naima, you will raise your hand. Of course, all of you will be mute during the presentation, but you can you have the hand sign here. You can and you have the question and answer. You can raise your hand or type your questions, and then we will answer your questions. I will be reading your questions to Dr. Naima for any further clarification needed. After the presentation, we'll give a brief time for discussing the case, and maybe also Dr. Asma Deep can comment on the case and ask further questions to Dr. Naima to clarify the case further. And after that, Dr. Asma Deep, she will have a presentation about the case. As I said, this is a new format, so this is our trial, the first time, and hopefully it's going to be successful and interesting for you. So we're going to continue to do this on a periodic basis. We have not really put a time frame how often we're going to repeat this. I assume that it will be based on the cases I receive from you. As I said, this format is depending actually on you, about the cases that you sent to me, and then we, the multi-specialty team, will select a case which we think interesting for both neonatologists and pediatricians. We're not going to make this forum only interesting for neonatologists. We'd like to expand this forum also for pediatricians. Finally, I'd like to thank Pearl Events for organizing this event. They've been actually working hard with us for the last few weeks to prepare for this format and all the other neonatal multispecialty format. With this, I'm going to leave the floor for Dr. Naima to start her presentation. Dr. Naima, thank you for joining us, and please present your case.
Good evening, everyone. Thank you, Dr. Hisham, for to give me this opportunity. First, I can make me a host to be able to share screen.
You are co-host, doctor.
Okay. Host disabled. Still not working. Still, I am disabled to work. Okay, work this way.
Dr. Naima, can you share the screen from down from the?
Yes. Okay. Okay. Today we will present a case for discussion. I will give some general background about the case first, and then we will discuss the problem of the case. And I hope that you share your thoughts while we are presenting the case. I have nothing to declare. Our case is a female baby, late preterm, 36 weeks gestation, born to 37 years old, gravida 6, para 6, healthy mother. The pregnancy was unremarkable and the baby delivered by cesarean section with a smooth resuscitation, and the Apgar score was 7, 9 at 1 and 5 minutes. And his gross parameter, he was appropriate for age, for his gestational age. Soon after delivery, the baby developed tachypnea and intercostal retraction and admitted to our NICU on a CPAP. And this is the cause of admission. Was on a CPAP for 3 days and then went to room air. By physical examination, the baby has some dysmorphic features. The breast nasal bridge, thin, smooth philtrum, thin upper lip, and underdeveloped mandible. Neurologically, the baby has some mild irritability, but has good tone and normal reflexes. The seizures not reported apart from one attack of myoclonic jerk. Chest bilateral good equal air entry and cardiovascular audible first and second heart sound with no murmur and palpable femoral pulse and oxygen saturation more than 95% on a room air. Abdomen soft and no organomegaly, and the baby tolerate full oral feeding average on day 4 or 5 of his age, and skeletal wise apparently normal. Initially on admission, the baby admitted on IV fluid on dextrose 10 in water, and on the second day, the sodium chloride and potassium chloride were added. On day 4, routine labs were sent. And this is the only abnormal laboratory test that came is the total serum calcium level was 1.47 millimole per liter, and the ionized is 0.15 millimole per liter. The baby was hypocalcemic, and the IV calcium gluconate started and retest again after 2 days, but the calcium is decreasing to 1.17 millimole per liter, and the ionized remain the same. This is our problem. What do you think what is wrong with this baby? Anyone can suggest?
So we'll give you time to think about the diagnosis and what's wrong with this baby. And if you need to comment, as I said, just write in the question and answer your comment, and then we will deliver it to Dr. Naima. Dr. Naima, just for clarification, you usually don't start calcium in the first few days for IV, as I see in Egypt, right? You avoid calcium in IV.
Yes, we don't start routinely.
So the baby was not given calcium, was only given sodium and chloride.
Yes.
So, sodium and potassium chloride.
Yes.
Okay.
The next step. We start to investigate the baby because they remain hypocalcemic, even the calcium is declining, and all labs were done, and all was normal, renal function and the serum albumin level, while the total serum calcium level is still declining to a degree of 0.67 millimole per liter, severe hypocalcemia, and the serum phosphorus level was 2.5 millimole per liter, which is within normal range for neonatal period. And while the serum magnesium level was low, 0.62 millimole per liter, and the paras hormone done for the baby at that time was in normal range, despite of the presence of severe hypocalcemia. And for the mother, the only test done for the mother is the total serum calcium level and the serum phosphorus, and both were normal. Based on this, we start to radiological investigation done for the patient was remarkable, either chest X-ray, echo, cranial and abdominal ultrasound. Based on the presence of hypomagnesemia, we start to correct magnesium level to with a single dose of IV magnesium, 100 milligram per kg per dose once, with the addition of oral calcium and vitamin D3 supplementation in these doses, and then retest for these minerals again after 2 days. The magnesium level is still declining, and magnesium was 0.49 millimole per liter, while the serum calcium start to increase, but still hypocalcemic, and the phosphorus level is within normal range. So due to the presence of hypomagnesemia, we give another dose of IV magnesium of a dose 100 milligram per kg, and start maintenance magnesium on 0.25 milligram per kg per day, and increasing the oral calcium and vitamin D3 supplementation, and then retesting. So at this point, the serum magnesium level become normal. The serum calcium is increased, but is still hypocalcemia, and the serum phosphorus is normal. At that time, we do the serum vitamin D. Unfortunately, it was not done before, and it is low also, 19.9. At this point, when the calcium is increased with correction of hypomagnesemia, do you think that hypomagnesemia is the cause? Anyone can share his thoughts with us?
Now we reached day 4, Dr. Naima, correct?
No, it is not day 4.
Day what now? 2?
Okay, sorry. We start with the day 4 at the time of presentation of hypocalcemia. But on this, we are on day 8 or day 10 at this time.
And now the baby was taking oral feeding or still on IV fluids?
On full oral feeding and oral supplementation and vitamin D. Yes.
As I told you during our discussion, the hypomagnesemia was strange. Hypomagnesemia is rare, except if you don't give enough magnesium. So if your baby stayed on IV fluid for a long time without magnesium, baby of course can develop hypomagnesemia.
Oh, the patient was on full oral feeding and no IV fluids, and magnesium is corrected by 2 doses cumulative 200 milligram per kg together with the maintenance. Despite this, the patient corrected later on.
I have actually some questions here. One question was the parathyroid hormone that you did was normal or no?
Yes, the parathyroid hormone was normal, but in the presence of severe hypocalcemia.
Okay, so the parathyroid was normal in the face of severe hypocalcemia. Yeah.
Yes.
And echo was done. You said echo was done and was normal.
Yes.
Did you think about any syndrome causing hypocalcemia, like DeGeorge? As you said, there is some dysmorphism.
Yes, this is what we think about, but unfortunately, we cannot do microarray for this patient because of financial issues.
Okay. You can continue.
After we maintained on the magnesium intake of oral supplementation for about 4 days, and then we discontinued the magnesium to know that it was the cause or not. We discontinued the magnesium supplementation for 4 days, and retesting again, the magnesium remained within normal range. the calcium increased to normal range and the phosphorus within normal, but the hormone was low. At this point, we exclude the hypomagnesemia. What do you think? What to do next for this patient?
I have some answers about syndromic causes like the George. Yes. You can continue.
Okay. At this point, we decrease the dose of oral calcium and vitamin D supplementation for half the dose and retesting again after 3 days, and came normal, in normal range, both calcium and magnesium level. And then for another 3 days, we completely discontinued the supplementation, and the patient came with the lab investigation was all normal, and the hormone at that time was on the low normal range. This is the end of our investigation done for the patient. Unfortunately, we not reached the final diagnosis, and this is the lab sheet for the patient all the time, the period the patient admitted in our NICU. The serum, reflection on what has been done, the serum calcium level does not start to increase unless the magnesium level is increased, and also with supplementation of vitamin D. While the hormone all the time on a low normal, on a normal range in the presence of severe hypocalcemia, and when it is increased, it is still within low normal range, while other investigation was normal.
So the baby is how old now?
The last time we test for the patient was the age of 32 days, about corrected age 40 weeks plus 1 week, or some days above. The patient now discharged for about 2 weeks, and unfortunately there is no follow-up for this patient because he not came again.
Dr. Asma, did you join with us? Are you in?
Yes, I am in, Dr. Hisham. Thank you very much indeed. I'm taking few notes, and I'm going to highlight a few points during my presentation, and then perhaps we can all join and comment together. I've been following very carefully. Thank you, Dr. Naima.
Would you like to ask Dr. Naima for anything now for further classification of the case?
Not really, but if Naima remains joining us, perhaps we can reconvene after I finish my presentation.
Indeed, Dr. Asma.
Okay, as you can see, of course, there is some differences in practice. Cases might be handled or managed differently in different occasions. That's why I invited Dr. Asma Deep to comment on the case. And as Dr. Naima mentioned, actually they did not have final conclusion of this case. So we invited Dr. Asma Deep to comment on the case, to maybe help Dr. Naima to reach a diagnosis, and also to have some comment about the hypocalcemia. So let me introduce Dr. Asma Deep for you. Dr. Asma Deep is a a consultant pediatric neonatology, and she's the chairman of the pediatric endocrinology department at the Sheikh Shaghbout Medical Center, SSMC, here in Abu Dhabi. She's Dr. Asma is a dear colleague and friend from a long time. I would like actually to thank her very much for the privilege of giving us this privilege to join us tonight. She's participated several times in our platform, and I always admire her presentations. Thank you, Dr. Asma, for joining us today or tonight, and I will leave the floor for you.
Thank you very much, Dr. Hisham. I really hope that I will not let you down after this beautiful introduction. And if I could please ask Rama to enable me, because it says host disabled participant screen sharing. Thank you, Rama.
You are able, Doctor. You can share your screen.
Fantastic. Thank you very much indeed. Okay, here we go. All right. Are you able to see my screen, Dr. Hisham and Rama?
Yes, we can see it, yes.
That's amazing. Okay, so what I'm gonna do is just to talk briefly about what we've heard from Dr. Naima, hypocalcemia in general, and I'm not gonna give a didactic lecture. You are a group, perhaps I'm the only non-neonatologist, so perhaps, not perhaps, I'm sure you know far more than me when it comes to neonate. And if we about complexity in medicine, my perspective is neonatology is incredibly complex, but also endocrinology is another complex subspecialty. And tonight we're talking about neonatal endocrinology, so it's all quite complex issue in medicine, and it would be amazing if we can have this as an interactive discussion, because there isn't black and white in medicine. So the definition of hypocalcemia, as we've heard from our colleague, the previous speaker, when it comes to biochemical definition, is that this is the reference I have, which I cannot see. I do apologize, at the bottom of the screen. So hypocalcemia is defined biochemically as total calcium of less than 7 milligram per deciliter, which is equivalent to, as you see, I've put millimoles and milligrams. I'm not sure you guys, which one do you use? And then another definition, not for the total this time, but for ionized calcium, which is below 1 millimole. Now, the complexity starts here, because in neonatology, reference ranges are not fixed, because gestational age is very important. And reference ranges, particularly in bone diseases and when it comes to prematurity, things get a little bit muddled up. So for the definition of ionized hypocalcemia, it depends on what the gestational age is. The reference I looked at says that for full-term babies, the hypocalcemia is considered when ionized calcium is less than 1 millimole. While if the baby is preterm, then a lower number or figure of calcium can be tolerated. And I am an endocrinologist, and we see this in the definition of hypoglycemia as well. So it varies. It's very important to know what the gestational age is, as well as preferably what the birth weight is and the current weight. The slight complexity also when it comes to the definition is not only we are talking about total calcium, because total calcium and the bound calcium varies in neonates, especially little ones and sick ones, because the albumin, which is the main protein that calcium binds to, can vary in these little babies, especially if they are sick. So sometimes we ask for corrected calcium. So this is just a quick introduction. Now, there are different ways to define neonatal hypocalcemia. We can talk about it of either transient hypocalcemia or permanent hypocalcemia, or another popular way of dividing this amongst yourself as neonatologists is early onset and late onset of hypocalcemia. So by the early onset, I mean that which presents within the first 72 hours, and it requires treatment with calcium. While the late onset, it presents later, and more often than not, it requires term treatment, sometimes even lifelong treatment. So it depends on of the hypocalcemia. So there are long lists of causes of hypocalcemia, and one of them is the hypomagnesemia. However, around the world, especially in the Middle East region, if we look at the column for the early onset hypocalcemia, we see that maternal deficiency of vitamin D is one of the very well-known causes. There are other causes in the early onset that falls in the category of the transient hypocalcemia, majority related to the maternal factor, things to do with preeclampsia, for example, or even maternal hyperparathyroidism. But for the baby, him or herself, prematurity, intrauterine growth retardation, asphyxia, and all others can lead to neonatal of early onset. But please keep in mind the maternal deficiency of vitamin D. I do not recall Dr. Naima mentioning that for mother. I think it wasn't done for the mother. And if it was, we need to know whether that can be considered as the cause of this baby's low calcium. There are things that pro this diagnosis, and there are things that are against, which we can discuss and debate. There are multiple other causes about the permanent, and one of them is what Dr. Hisham highlighted, is not uncommon, DiGeorge syndrome, the chromosome 22 microdeletion in the long arm of chromosome 22. This is a very interesting entity, and it's not uncommon in our region. So I understand that the echocardiography was done, but it's not necessarily to have all the components of DiGeorge syndrome to reach to its diagnosis. So microarray will be very useful. I'm not very good at this morphology, but the baby might have some features that fits with DiGeorge syndrome. I do not recall the X-ray that you showed, Naima, and whether there was any thymus shadow showing, because in this syndrome you get thymic aplasia or hypoplasia, so there's no thymus shadow in these babies, and this leads to lowered immunity and multiple infections. So that could be another reason for what you have presented. Now, going back to the vitamin D of the mother, this is a global thing. It's not purely in our region, either in North Africa, where Naima practices in Egypt, or we practice here in the United Arab Emirates. But the low vitamin D, low maternal vitamin D is a common condition. So I got this interesting reference showing maternal vitamin D level at different gestational age from different parts of the world, and it can be variable. So I circled two with red for you, one from India, and as you can see, they looked at women at all gestational ages, and 96.3% of those women fulfilled the diagnosis or the criteria for diagnosing vitamin D deficiency. On the other hand, in Indonesia, this study showed that only 3.1% of those mothers have low vitamin D. And you might think, okay, vitamin D is related to sun exposure, and the Indonesian women are covered, and you think maybe they will be having more prevalence of vitamin D, but This is not the case based on this reference, because in India, where we assume there's more sun exposure and women are not necessarily all covered with the Islamic hijab, but according to this study, the incidence is in Indonesia is much lower. And this is interesting because it tells you that vitamin D is not purely dependent on sun exposure. There's lots of other things that affect level of vitamin D, including nutrition, dietary habits, as well as, very important, the genetic factors. So what I'd like to go through here, and Dr. Hisham, do please feel free to stop me at any time if you think that I'm deviating from the main aim of the talk, or if there are any questions from colleagues. But I'd like to just give you some historical background on these interesting areas of metabolic bone diseases in neonates and in children in general. So if we talk about rickets, rickets is not a new thing. And hypocalcemic rickets in particular has been described more than 4 or 5 centuries ago. And people in the early of 20th century started thinking about vitamin D and how that can prevent or treat hypocalcemia and avoid the children having deformities. So from the early 1920s or before that, people started thinking about giving cod liver oil, which is rich in vitamin D. People started thinking about sun exposure. And more commonly, or more recently in 1930, people started linking hypocalcemia and rickets and deformities to vitamin D. Now, I'm hiding my, okay. Now, if we talk about nutritional rickets, you might be thinking, what are you talking about? There's no longer nutritional rickets, but I reassure you, there are still nutritional rickets, even in well-developed countries. A common cause, for example, perhaps you guys as neonatologists see, babies with multiple allergies who go into those very strict formula. I recall one called Neocate and others, where children are deprived from many nutritive values like calcium and phosphate and others. We do still see nutritional rickets. And while it was eradicated from the United States in 1945, it did come back. So people around the world start seeing nutritional rickets coming back again. So do keep this in mind when you are facing children with malnutrition or children with severe allergies and those who are on special formula. They have those classical features of rickets. And let me now just go and have this summary with you. If we talk about hypocalcemia and rickets in general, then if we start talking about what causes that, and if we start by talking diet and intake, that's incredibly important, as well as exposure to the sunshine. There are many other organs that are important in the body to facilitate the bone health and keeping calcium, phosphate, magnesium, and others within normal range. We need the adipose tissue. For that, we need the liver and we need the kidney, of course, to have healthy bone. So it's more of a multidisciplinary work between our human body and organs so that we end up having normal calcium, which we take it for granted. Okay, so, I don't know. Okay, here we go. So if we don't have the proper nutrition, if we don't have the proper sun exposure, we will be having hypocalcemia, perhaps with nutritional ricket. And the key to nutritional ricket is that with hypocalcemia, sometimes we have a normal calcium or borderline low calcium, but the vitamin D 25 or the dihydro active form of vitamin D, both of them will be low. That's straightforward. And again, going back to your case, Naima, I think you showed hypocalcemia and you showed low vitamin D level. So there is still possibility that this is maternal vitamin D deficiency. Now, if we move to the next step of vitamin D, what we normally have is after having vitamin D from the adipose tissue, we need vitamin D to be hydroxylated into 25 hydroxy vitamin D, and that happens in the liver. I have recently seen a child who has 25 hydroxylase mutation, and that child had very low 25 hydroxylase and very low 125 as well. And this is because of genetic mutation. And it's not uncommon. I have a colleague in Saudi Arabia who have around 50 families with this condition. It's purely a genetic condition, autosomal recessive, when you cannot hydroxylase the vitamin D to make 25 hydroxylation. The step after that in vitamin D activation is you take it from 25 hydroxy vitamin D to 125 dihydroxy. And that step is when we need the kidney, because the kidney does this dihydroxylation. So you have two atoms of the hydroxylase. Now, there are two types of defects here that we can end up having. The first one is if we have one alpha hydroxylase deficiency because of gene mutation, then we end up having 25 hydroxy vitamin D, which we cannot convert to the active form. So when you look at the blood test, you will find high or normal level of 25 hydroxylase, hydroxy vitamin D, but the 125, it will be low. And let me tell you another interesting step. It's not enough to reach all these steps and do this hydroxylase work. You need to have receptors that is active. So when 125 dihydroxy vitamin D binds to those receptors, we need active receptors. But sometimes what happens is we have mutation in those receptors. So even if we have high vitamin D, even the 125, you'll find it high, yet you have hypocalcemia and you have rickets, and that could be because of this receptor mutation resulting from vitamin D dependent ricket type 2, which is an end organ resistance. And if we leave all that apart, the story is not finished with hypocalcemia and rickets and deformities, because there is another entity of rickets that we need not to forget. I know Naima concentrated on calcium. She talked about magnesium, but phosphate is another very important element that we need not to forget, because if we talk about parathyroid hormone, it works in both. Now, hypocalcemia, I'm sure you've seen many children and or babies in the NICU, and if you are talking about the acute presentation of hypocalcemia, then you'll be talking about hypocalcemic tetany. Some children have seizures, others have milder forms, so they might just have a twitch in their skeletal muscles. And then as babies grow older, you see other features. And the features of rickets, if the cause is not treated, becomes more apparent. So the abnormal shape of the head, the enlarged open fontanelle, even beyond 18 months of age, you see those widened wrists, like I'm flagging up in the slide. You see the widened ankles and also the teeth. Calcium and vitamin D are very important for the healthy development of the teeth animals, and this can be defective too. And as you graduate your babies from the neonatal units to us in pediatrics, we see a different clinical feature. So the deformities, particularly in joints like knee and ankle, which are the weight-bearing joints, can have different deformities. So you see bow legs, or you see gynovalgum legs like what I'm showing here. Now, one very important feature that we have not been really paying attention to sometimes in children, young children, older children, or even adolescents is limb pain. Hypocalcemia, and especially vitamin D deficiency, can give these vague symptoms of fatigue. People who run clinics for adolescent medicine, they are experts in pain, and a good proportion of their patients, they do have low vitamin D, because it not only is important for bones, but also it's important for muscles. And it can give you this picture of myopathies. So now I'm coming back to hypocalcemia and hypophosphatemia. These are very important components for important bone health. So if we leave the acute manifestation that you guys see at the NICU, and then you think about what happens to children when they grow up having hypocalcemia or rickets in general, then do please not forget hypophosphatemia as well. So in your left-hand side, you see that I have listed some forms of rickets. So we talked about nutritional rickets. We talked about D1 alpha hydroxylase deficiency. We talked about type 2. And then I'm going to also highlight the hypophosphatemic rickets, because people get excited about calcium, they do alkaline phos, vitamin D, and PTH, and not many people look at phosphate, particularly urinary phosphate, and I'll tell you why that's very important. So if you look at this grid, you can see that alkaline phosphatase is going to be high in all types of rickets. Alkaline phosphatase is not a specific analyte. It just tells us that there is a bone formation. And if you look at the panel under calcium, you can see that calcium might be normal in nutritional rickets, and it is normal in hypophosphatemic rickets, but it's low in other types. If you look at the phosphate, you will find it low in majority or almost all types of rickets. So it's a fundamental element when we talk about the bone metabolism, and it's very important that you look at it. 25-hydroxy vitamin D can be expensive, and it's not covered by most insurance. I don't know about you, Dr. Hisham, in Corniche, but where I practice, because people started doing it left and right for everybody, so insurance mandated some indications for covering vitamin D, so osteoporosis, osteopenia, but not others. And it can be expensive if people are self-paying for it. 1,25-dihydroxy vitamin D is even more complex because it's expensive, and specific subspecialties where I practice are allowed to request it, like rheumatologists, oncologists, and not everybody, definitely not general pediatricians, not even endocrinologists at the beginning, until we made a fight about it and we managed to prescribe, to request it when necessary. So you've heard from Naima a very interesting case about hypocalcemia, and we are still debating as to what's the cause of that. But let me very quickly present a different angle of issues related to bone, metabolic bone diseases, deficiencies of analyte, and what happens to PTH, phosphate, alkaline phos, and vitamin D. So this is a little baby boy, 18, sorry, it's not 18 years old. He's only 18 months old. So started walking or started standing up at the age of 10 months. And as he continued to learn how to walk, his parents noticed that he has a deformity. Not only that, but he gets tired very easily. He is low in height, and an interesting feature in him is that he always had sore gums and what it looks like after ulcers in his gum, even at this very young age. Something that I'm very proud of, and I will continue to be proud of being a pediatrician, because pediatricians do take very good history, and they are very good historians, and they do listen to families. So the history here is that mother, who is 36 years of age, very short mother, also had bowed legs. And trust me, it can be very tricky because people are well covered in our region. So it might go unnoticed. And I know it's difficult when a mother is bringing her child for consultation and you turn up saying, can I examine your legs? It's not easy, but we need to know that information and tease it out. Not only that the mother was short, not only that she had bow legs, but she also wears partial dentures and she has a hearing aid. I don't know if people want to flag up any ideas, but for the sake of time, I will continue telling you what this is, and then we can open the discussion. But again, Dr. Hisham, do please feel free and interrupt me. So let me show you the investigations now so that we can compare this patient to the patient that Naima presented, so that we have a feel about different forms of metabolic bone diseases. So here, the corrected calcium is normal. But if you look at the phosphate is significantly low. Alkaline phosphatase is high. It's not going to help me. It's expected to be high. I'll be worried if it is low. We see low alkaline phosphatase in very rare cases of hypophosphatasia. And hypophosphatasia is another interesting genetic condition that presented during the neonatal period. Most of the times it's neonatologists who see this condition. And it's the infantile form and the perinatal form is associated with very poor prognosis. These children, they die with respiratory failure and they have hypercalcemia and their alkaline phosphatase is very low. But let's leave that aside now. We are talking about a child who presented with bow legs. Mother had the same history. The calcium is normal. The phosphate is very low. Alkaline phos is high. And listen to this. Now, the PTH. The PTH is low. Okay? And you might say, no, it's not low. It's 7.1. But it's normal to only slightly high. PTH is very useful. Naima kept reminding us that her PTH was inappropriately normal, because with that level of calcium, you expect the PTH in her case to be quite high. This is the appropriate feedback mechanism between the calcium and the PTH. Hers, the PTH, I think in one it was 35 and then it was significantly low. That's inappropriate. Even if it was normal, in her case, it's inappropriate. Here, in this case, it's only slightly elevated. PTH will be very high in hypocalcemia in general, and particularly in nutritional ricket associated with hypocalcemia. So let's continue on this child. So this child had normal vitamin D, 25 hydroxylase, and slightly low 125 vitamin D. Okay, so you might say, okay, well, there is a problem in converting 25 to 125. You are right, but in that case, we don't really see hypophosphatemia and the PTH will be very high. So it's not 25 hydroxylase deficiency, this case is. And let me give you some more clues so that you can reach to the diagnosis. Now, TMP, tubular maximum phosphate reabsorption ratio with the GFR is 0.58. We use this to assess the urinary phosphate. In this case, the urinary phosphate is high, and this ratio is low because you expect the tubules in the kidney to reabsorb more. So now you can conclude that the hypophosphatemia is likely to be associated or caused by the phosphate leak in the urine.
So, Dr. Asma, sorry, this is based on the measuring urine phosphate, the TMP GFR by measuring the urine phosphate, as you stated before.
Very good question, Hisham. This is a formula that you can either have it in an app and you put number and it comes up, or you can do serum phosphate, serum creatinine, urinary phosphate, urinary creatinine, you work out the formula, and then you look at in a normogram that's available in all the neonatology and the pediatric books.
Okay.
So after you apply that formula, you come up with a number, and then you go to that normogram, and it tells you what the tubular reabsorption of phosphate is. In this case, the tubular reabsorption is low because the urinary phosphate is high. And now one other differential that neonatologists know more than us is things to do with Fanconi syndrome, where you see those children who leak everything in the urine. Nephrologists are good at that as well, because these children, they will have glycosuria, they will have proteinuria, they might have amino aciduria, and it's related to renal tubular acidosis. These children are acidotic as well. But in this case, there was no glucose in the urine, no amino acid in the urine. All what it was in the urine is phosphate. And there was no calcium. Calcium was within the normal range. So this is the summary. And I think, I'm not sure if somebody is raising. Somebody here says that, I don't know if it's a comment about Naima's case. I think it's Naima's comment on Naima. Sorry, I got excited. I thought somebody is responding to my case. Okay, anyway, so now we have a form of hypophosphatemic rickets that's more likely to be genetics because the mother has the same. We have normal serum calcium, we have lots of phosphate leaking in the urine, and we have slightly elevated PTH, and we have a normal vitamin D and slightly low 125. In this case, we will need to do one more thing, which is something called FGF23. So FGF23, we started learning about it recently. It's fibroblast growth factor 23, and it's a very important component in the work for metabolic bone diseases. This factor is very important in the metabolism of phosphate and calcium. And I will come back to it in the next slide, but this picture that I have highlighted now is classical for X-linked hypophosphatemic rickets. In hypophosphatemic rickets, the XLH form, you will find very high component called FGF23 in association with low phosphate in the serum and very high phosphate in the urine. The reason why I came to know about this is because it has been a hot topic in metabolic bone diseases and endocrinology over the last 2 to 3 years. And you might guess it became very popular and a hot topic because there is a novel medication, a monoclonal antibody that came for treatment of this condition. Children and adults with this condition suffer from the deformities and multiple comorbidities. And the conventional treatment, as you might have guessed, is replacing phosphate, replacing active vitamin D, but it's not easy. It's a very complex treatment. And now with this novel medication, we started getting excited about knowing all types of metabolic bone diseases. We started understanding more about even simple cases like the one I presented, like the one Naima. People neonatologists, endocrinologists, and metabolic bone disease people started to understand more about bone health and how to interpret properly the metabolite related to bone disease. And let me tell you why it is very important, because people who have X-linked hypophosphatemic ricket, they do suffer. It's a multisystemic disease. The bones, the teeth, the skeleton in general, the muscles, the growth is all affected. And the conventional treatment consisting of phosphate orally and active vitamin D is not very effective. In fact, it has lots of side effects. If you get the opportunity to try drinking phosphate, do. But I warn you, it's horrible, very bitter. And the problem is phosphate has a very short half-life. So to replace phosphate, you need to give it 6 times a day. And imagine something bitter that you need to give to children. So it's next to impossible treating this condition. It affects pediatrics, it affects adults, and it might be severe enough to be evident right from the beginning in the neonatal period with abnormalities of the head shape, which I have one child that I have seen right from 3 or 4 weeks of age. The teeth in this condition is very interesting, and dental care is very important, because in this condition, the root of the teeth is abnormal, giving access to bacteria. And these children, they present with multiple abscesses. Last week, I have one of my XLH patient who needed admission and IV antibiotics for many days with involvement of maxillofacial people because of this condition. So do please look at it, or look for it rather. So when we talk about the equilibrium between calcium, phosphate, magnesium, PTH, vitamin D, you name it, there are 3 main organs that interplay within this. Not only the bone, but we need kidney, we need liver, and we need the intestine as well. Because 30% of dietary phosphate through the small intestine, it occurs and it's regulated by the active form. So you need the active form of vitamin D to absorb phosphate. And majority of the phosphate or the phosphorus that's filtered from serum gets reabsorbed by the kidney. So we need good kidney, we need good intestine to have good bones. But what we didn't know, I knew it only recently, even though I practiced pediatric endocrinology for over 20 years, I came to know recently that this new analyte, FGF23, is very important in this scenario of phosphate homeostasis. It's not only active vitamin D, it's not only PTH, but this component is very important. And it's exciting when our knowledge increases and when we can take science into the bedside next to the patient. Because the more we know about basic science, the more innovation comes and the more we can serve the patients in better way through innovation and coming up with new medications. So if you are still wondering what FGF23 is, well, it's a component that is expressed through a gene called PHEX. PHEX, I can't remember what it stands for. I'm really sorry. So PHEX gene. If you have PHEX gene mutation, there is overproduction or overexpression of FGF23. And if you have lots of FGF23, it's a problem because it impairs the work of the active vitamin D, and we do not get the phosphate absorbed from the intestine. Not only that, but it inhibits the reabsorption from phosphate through the kidney, and we end up leaking phosphate in the urine. And that's why I said, if you are stuck and you don't know what the cause of this ricket, it's just you don't know, then you need to look at serum phosphate. And if it is low, you do PTH. If it is normal or only slightly elevated, because it should be very high in other forms of rickets, do think about X-linked hypophosphatemic rickets, and do ask for FGF23. We don't do it in our hospital in Abu Dhabi, but we send it out, and it's not expensive to get it done. So I have few patients, and I managed to get it even with those who are self-pay. So I'm going to skip this one because we have talked about it, and I'll just summarize here because I'm anxious about the time. So the XLH, again, I keep repeating because I would really love to get to take this platform to highlight how important ricket is, metabolic bone disease is, and particularly XLH, because really the novel medication is incredibly efficacious and safe for patients. So FEX gene mutation is what we look for in the genetics. It causes increased expression of FGF23. That leads to renal phosphate wasting, low 125 hydroxy, no reabsorption from the intestine, so we lose the phosphate in the urine, and we end up having hypomineralized bones, even though we have enough calcium, but we need phosphate to work with calcium to have the normal bones. So this is the algorithm that I'm not going to bore you with, but I'm sure you know very well the use of this. So if we have a child with clinical form of ricket and low serum phosphate, you will be asking yourself, is this patient having low phosphate because he or she is leaking phosphate in the urine, or the excretion is normal? If this patient is leaking phosphate in the urine, then you will be thinking, does the patient have low or normal PTH or have high PTH? If the PTH is high, then this is classical for either hypocalcemia, like what Naima presented, deficiency of vitamin D, abnormalities of vitamin D, the others that we talked about it, if the PTH is high. If the PTH is low or normal, then you do 125 hydroxyvitamin D. And if it is low, then you got your diagnosis of XLH. I did talk about the conventional treatment. The metabolic bone disease in general depends on replacement therapy, majority of the diseases. However, nowadays we started getting new forms of treatment. So we hear about the enzyme replacement for hypophosphatasia. For example, hypophosphatasia, as I said, it has very low level of alkaline phos. And recently, Alexion company came up with innovation of recombinant alkaline phosphatase, and it's a miracle medication. XLH is another form of innovative treatment where the FGF23 is high, and this monoclonal antibody just traps the FGF23. Because if we are relying on conventional treatment of replacing phosphate, not only that it's horrible to taste and it needs a very good compliance from patient, it's not always effective in bringing phosphate level to normal. This is the mechanism of action. So the medicine is called burosumab, and it's monoclonal antibody, and it reverses all what we talked about in terms of the leak of the phosphate and activating the active form of vitamin D, so we can reabsorb phosphate through the intestine. So what it does, it just binds to the excess FGF23 and reduces its action. So, ladies and gentlemen, I would like at the end to sum up the slides that I have shared with you. And I would like to highlight how important hypocalcemia is. It's a very important diagnosis to make during the neonatal period, because you might end up having acute complications of convulsions and cyanosis and respiratory distress, things that you know far better than me. It's very important to detect it, prevent it, and treat it. But we cannot treat properly unless we know what the underlying cause is, because we don't want things to recur. So we always need to keep a wide differential diagnosis and be a pediatrician. We are really good at taking history, regardless of how modern medicine is advancing and these applications and artificial intelligence and this and that, we still need our proper thinking from the time we were medical students, because otherwise we will just be made redundant and rely on computers. Now, we need to remember that hypocalcemia is not the only cause for rickets and metabolic bone disease. Please do not forget phosphate and the relations between the two. And family history is very important. That can give a clue to many genetic causes. And especially in a region like MENA, Middle East and North Africa, with the consanguineous marriage, many of these diseases are autosomal recessive. We need to have proper knowledge of metabolic bone diseases, starting from the neonatal age group and onwards until we go to adult endocrinology and rheumatology. Why? Because if we don't understand what's going on properly, we will end up underdiagnosing or even worse, misdiagnosing. One of my children or my patients with XLH had a mother with bow legs, and she has been mistaken for osteogenesis imperfecta, and she has been having pamidronate, which is a very well-known contraindication in this condition, but people didn't know about XLH. Hence, we need to continue. And thank you, Dr. Hisham, for giving us this opportunity to meet and learn and doing grand rounds, not only in endocrinology, but different subspecialties. And my last point in the conclusion is, remember, novel medications, monoclonal antibodies, all these biologics are very expensive treatment, but they are novel and innovative, and it can change the life of these patients. And with that, I'll stop talking and leave the floor for our chair. Thank you very much, Hisham.
Thank you very much, Dr. Asma. I'd like also to invite Dr. Naima, just in case if you have questions or comments. Dr. Asma, let me just summarize for you what happened in this case, Dr. Naima's case. As you can see, in Egypt, they don't put central lines. They depend on peripheral IVs, and they avoid calcium in the first few days of life to avoid burn. So they don't give any electrolytes except sodium and potassium only in the IV. So if the baby is not feeding, he will not get calcium, and he will not also get magnesium. By the time Dr. Naima contacted me, the babies actually, they were giving a lot of vitamin D, a lot of calcium, many magnesium IVs, and things were correcting. But let me tell you my thoughts about her case, and maybe you can help me also comment on, maybe to help her reach a diagnosis, and also for the audiences to have some experience with her case. So I had three differential. The first thing, that the magnesium was low initially, and as I said, magnesium, hypomagnesemia is very rare. The main cause for hypomagnesemia actually is decreased intake, and the baby did not receive magnesium maybe for a few days initially. The second thing, that as you mentioned in your presentation, the parathyroid hormone was normal in a phase of severe hypocalcemia. So this is alert the diagnosis of possible. The main cause for hypomagnesemia actually is decreased intake, and the baby did not receive magnesium maybe for a few days initially. The second thing, that as you mentioned in your presentation, the parathyroid hormone was normal in a phase of severe hypocalcemia. So this is alert the diagnosis of possible. The main cause for hypomagnesemia actually is decreased intake, and the baby did not receive magnesium maybe for a few days initially. Trauma. The second thing, that as you mentioned in your presentation, the parathyroid hormone was normal in a phase of severe hypocalcemia. So this is alert the diagnosis of possible. The main cause for hypomagnesemia actually is decreased intake, and the baby did not receive magnesium maybe for trauma. I think there is trauma for the second thing, that as you mentioned in your presentation, the parathyroid hormone was normal in a phase of severe hypocalcemia. So this is alert the diagnosis of possible. The main cause for hypomagnesemia actually is decreased intake, and the baby did not receive magnesium maybe for
Trauma, I think there is trauma for
the second
for
thing
the
that
sound.
here, as
Doctor,
you mentioned in your
are you
first
opening
presentation,
another
the parathyroid
file?
hormone was normal in a phase of severe hypocalcemia. So this is alert the diagnosis of possible. The main cause for hypomagnesemia actually is decreased intake, and the baby did not receive magnesium maybe for
Trauma, I think there is trauma for
the second
for
thing
the
that
sound.
here, as you
Doctor,
mentioned in your
are you
first
opening
presentation,
another
the
file?
parathyroid hormone was normal in a phase of severe hypocalcemia. So this is alert the diagnosis of possible. The main cause for hypomagnesemia actually is decreased intake, and the baby.
Should I log off and come back? Or what?
Magnesium maybe for
Trauma, I think there is trauma for
the second
for
thing
the
that
sound.
here, as you
Doctor,
mentioned in your
Yes,
are you
yes.
opening
presentation,
another
the
file?
parathyroid hormone
No,
was
no, only
normal
this
in a
computer.
phase.
Oh, okay. Sorry for this mechanical interruption. So as I mentioned, Dr. Asma, the thought was hypomagnesemia and maybe hypoparathyroidism. That's in the fact that parathyroid hormone was normal with this severe hypocalcemia. And the third was that maybe it's like genetic issues like or a syndrome as the George, as she mentioned, there was some facial dysmorphism. So because they were already given a lot of calcium and magnesium, the magnesium and the phosphorus were the calcium and magnesium they were slowly improving. But I think all these injections mask the diagnosis. So the advice to her that to stop all these supplements and wean the baby back, and stop all this calcium intake, stop magnesium intake, and then remeasure the hormone again and remeasure the electrolytes just to have a sense where is the diagnosis. And as you can see there, the parathyroid hormone is now low. With being the calcium is already corrected, the parathyroid hormone is becoming low again. So what do you think? And do you think that this can be a case of hypoparathyroidism? I saw your presentation and you pointed out that the diagnosis of late hypocalcemia starts after 1 week. I think this baby presented a little earlier, like 4 or 5 days. It's somewhere in between early and late hypocalcemia. So what's your thoughts about the case?
Okay, thank you very much, Hisham. I think I also looked at the Q&A boxes, and many people are still thinking about the possibility of hypoparathyroidism under the umbrella of DiGeorge syndrome. I think we need that diagnosis excluded, so that still remains high in the list. Again, congenital hypomagnesemia, and you know better, is a rare entity, but it doesn't mean that it doesn't exist. So sometimes even we see children who are not necessarily premature or asphyxiated, but they still have low magnesium. And magnesium is very important for parathyroid action and even the level of the parathyroid production. So I don't know, it's like the chicken or an egg, which one started first and caused the other. I don't really know. I'm still gonna go around and keep thinking, is this hypopara because of DiGeorge, or is this hypopara because of any other genetic condition or mutation? Is this hypopara because the child, I don't know about the family history, but it could be part of the polyendocrinopathy syndromes, like type 1, for example, has hypoparathyroidism, candidiasis, and others. So is there a family history of a collection of endocrinopathy syndrome? It could be the first presentation, hypoparathyroidism in this child. I was expecting, or I am expecting, a little bit higher PTH if it is due to maternal vitamin D deficiency, but it's the other way around. So I'm not going to put my money on anything because I'm not rich to start with. And a doctor can never be rich, but I still think that it could fit into hypoparathyroidism, but we need to know what exactly. I would love to see a microarray in this child, and I would love to know more history from the family if there's any other polyendocrinopathy syndromes. We need to know details of maternal, and more importantly, more important than all this, what's the progress of the baby? I know, like many children or patients of ours, they fail to follow up, and that's what happened with Naima's patients. But it would be nice to see what happened. He might prove us wrong, and he might come into clinic with everything has returned back to normal. I don't really know. So I'm afraid I'm not going to add many golden wisdom here, Hisham, on this case, more than what you have already stated.
Yeah. The advice to stop all these supplements is just to clarify the diagnosis, because that's what was my advice to her. Stop all these supplements because they are masking the diagnosis, and it did not. We don't have a diagnosis after this. Do you think this was a correct approach to do, or would you do something?
I think it's very difficult. First of all, it was a neonate. The reference range can be complicated. And then you are absolutely right. In bone diseases, you treat something, you mask something else, and you disrupt this feedback that God created us human with. So I think if the child was not symptomatic and he was not critically ill because of lack of these analytes, I think stopping them is not a bad idea. Mm-hmm. But I'm really itching. I would love to see what happened to the baby now.
Yeah. I think that this will be a very important to follow up and see, and that's what we aim, to stop everything and keep testing the baby just to see what's happening with the baby, so we can reach a diagnosis. You mentioned also in your presentation that some labs are expensive. And I think in a country, and we have actually audiences from 6 or 7 different countries with us here tonight. In a country like Egypt, I don't think these labs will be available there. What will be the initial investigations that you would do in a case like this? When the baby present like this, what you would like to do initially before you start managing this baby, just not to mask the diagnosis?
I think the proper clinical thinking and the experience is more important than money. Money is important, but I think if we start logically, I don't think we will reach a diagnosis of the cause if we don't have a minimum of serum calcium, serum phosphate. Alkaline phos is very important. Now, these 3 are essential, and I think they are available, widely available. Then it depends on the country. If you do these 3 and you still don't know the diagnosis, then I don't know what I will choose between PTH or vitamin D. PTH is a difficult test to do because you need to take the sample, you put it in ice, you run to the lab, and it's expensive, but it's very important. Yeah. So perhaps now I'm going to take it back when I said money is not the most important. It's very important that we have PTH. But the interesting part, Hisham, even if people have the money, we ran a survey in our Arab Pediatric Endocrine Society, and we gave people a case scenario of hypophosphatemic rickets. And believe it or not, more than half of those people who are practicing, majority in the Gulf, they didn't even think about urinary phosphate. They have the money, it's not an issue. I don't blame people not doing FGF23 because it's something that's becoming new in science and in medicine. But people need to utilize what they have. And sometimes, like you said, stop everything. Let's clear the blood, wash it out, and start fresh.
So the urine phosphate, you will send, urine phosphate, I think it sounds like it's very important investigation to send in any case of hypocalcemia. It just that will help to reach a diagnosis.
If you are able to send the initially serum phosphate initially, and whenever serum phosphate is low, then urinary phosphate becomes a must.
Yeah. So I guess for her case now, the labs that we repeat as outpatient after stopping all this supplement will maybe help now to clarify the condition. And we mentioned also microarray to add for her the investigations, if possible.
I hear about the National Genetic Center in Cairo. They are very active and they do a lot of sophisticated even molecular genetics. Can they not help with the microarray? Is not expensive. Well, it is. It's 1,000 dirhams in UAE, but I hear about
8,000 pounds now in Egypt. 8,000 pounds.
This is based also in national.
Dr. Naima, can you join with your camera, please?
Yes. Okay. I have some comments. First, we from the start, we not give the patient calcium supplementation when it is expected that the child reach full feeding within 3 to 4 days. This is not a routine. The patient that has conditions that make the feeding delayed or progressing slowly, the calcium IV is given. Is not for all the cases, because this patient is sound to pass in a straight course, so we not start calcium from the start. This is first. The second one, the family history. What we know that, as Dr. Asma comment on the family history, the father has 2 sibling deaths from another wife, but he not know the cause.
Father has what? I'm sorry?
2 sibling deaths.
Has death of some kids.
Yes.
Okay.
But he didn't know the cause. Okay. About the microarray is based in all institutes in our country, so we cannot do it. Dr. Asma, I want to ask you about this case. We have also
Naima, sorry, Naima, can I comment on you mentioned 3 points now. Can I just comment? So for the family history and these are they cousins' death or siblings? Siblings, okay, because it might be a long shot, but some genetic polyendocrinopathy syndromes, in which hypoparathyroidism is one of them, is also associated with hypoadrenalism. So some of these polyendocrinopathy syndrome, you find that patients, it's different types. And in one type, there are hypoadrenalism. So sometimes adrenal crisis can happen and it can be lethal. And people do not know the cause for that because it can be silent. So I'm just trying to link this important information that you're giving. And then going back to your first point, about giving calcium or not giving calcium by IV, I haven't done much neonatology. I found neonatology very intensive for me. I have a very weak heart. I cannot do intensive medicine. But do you give calcium by nasogastric tube? Or, I mean, if you are worried about the parenteral cause, IV, do you give oral calcium or through a tube, or do you use that?
Can give oral calcium, yes.
No, routinely, she means routinely. In the first few days,
it's not routine.
Yeah, they don't give any calcium. They hope that they're gonna start feeding soon after the delivery.
All right. Okay. All right. Sorry, Naima, I interrupted you. You were about to raise a question. Apologies.
No. Doctor, our case has normal phosphorus level all through. This in the presence of hypocalcemia, and vitamin D is low even after vitamin D supplementation. I cannot link these with each other.
Yeah, that's interesting. Yeah, because if you have hypoparathyroidism, then you expect the phosphate to be high. I don't really know. I would love to pause everything, get the baby to come back to clinic and have a fresh sample with no treatment, because I agree with you. When we try to link things with each other, not everything fits.
Yes. Even with vitamin D deficiency, the phosphorus is within normal, it's not low.
Yeah.
Yeah, that's true.
Where is the baby now? I have a comment there. Where is the baby? They ask.
The baby with his mother is not with us.
Discharged, but is it possible to bring the baby again for follow-up or no? Or the baby is lost?
I will try.
Yeah, that's very important, because the baby might have still hypocalcemia again after we stop all this treatment.
We discharge the patient with supplementation of calcium and vitamin D for fear of hypocalcemia, and the parents is not aware and of low educational level. So we discharge on a supplementation, not totally. Yeah. This discontinuation was in the hospital, and when discharged on a supplementation. I cannot judge for
whatever. I think this baby you should have a follow-up. If you have any contact with the family, it's very important to bring them back. Yeah. Okay. Any other comment, Dr. Asma, you have?
Just one thing, it might not be important, but because we're talking about metabolic bone diseases and novel medications, in some of these hypoparathyroidism and polyendocrinopathy syndromes, people can use recombinant PTH. Sometimes when you give replacement therapy in some conditions, not necessarily hypopara, when you replace with calcium and active vitamin D, you end up leaking a lot of calcium, leading to nephrocalcinosis. So some of the conditions people came up with recombinant PTH, and it can be useful in some conditions of low parathyroidism or low parathyroid gland.
Okay. Dr. Naima, you have anything to say?
No, I would like to thank you, Dr. Hisham and Dr. Asma.
Thank you very much. I have actually some comments about on the case from the audiences, and I think they're sharing the same thing. It would be interesting to repeat the test again after outpatient, after you stop these supplements, and this might help to reach a diagnosis. Yeah. And I think this death of these siblings raise a flag, like Dr. Asma mentioned, about some genetic abnormalities. And somebody mentioned here that the microarray can be done in the hospital 57357. I don't know free or not, but somebody wrote this comment.
Maybe the attendees should raise money for this child to get the test. That would be great. Done.
Actually,
I can contribute.
We have 500 actually with us in Zoom, and another probably 400 or 500 in YouTube. So we have 1,000.
So,
everyone give $1.
Yeah, $1. $1 each. $1 each.
Yeah.
Yani, I was in Egypt last week, and it's what, 34 جنيه الدولار ولا 30
yeah 40
جنيه is it 40? Oh, I have been cheated on then. Okay, so we can I'm sure we can manage for this baby.
Okay, this will conclude our night, and I cannot thank you enough, Dr. Asma, for joining us tonight and for this interesting presentation, and actually standing the hypocalcemia, not only for the neonatal hypocalcemia, but also for the rickets and the rare form of rickets for this, very useful for the pediatric population. And I'm sure there is a lot of pediatricians joining us also tonight. So thank you very much for joining us. And it's been a pleasure always to collaborate with you. Dr. Naima, thank you very much for the nice presentation. And I know I tired you in the last few days for keep fixing the presentation. So thank you very much. The last thing I want to say is about the CME. I have a lot of questions about the CME. This event is credited by the head, okay, from the Department of Health in Abu Dhabi. It should be accepted in all the other Emirates, but for the Saudi, we do not have accreditation from the Saudi. It's actually maybe your job to ask them to accept this. I'm not sure if they accepted there or not, but we did not seek accreditation from Saudi. Maybe for the future event, we will obtain also Saudi accreditation if they agree to accredit our events webinars. I thank you very much. And again, the last thing I want to mention is thanking Pearl Events for organizing this event and all the other platforms. And as I said, this is a Neonatal Multispecialty Grand Round. This is the first episode. Hopefully we will repeat it again. Especially if we hear good feedback from you, and if you share your interesting presentation with us, then we will advertise for the future event. Thank you again, Dr. Asma, and see you inshallah in the near future in another presentation. Thank you very much.
Thank you very much. Thanks, Hisham. Thanks, Naima. And thanks also to Rama. She's been great and very patient. Thank you very much. Thank you very much.
Thank you, Rama. And thank you all the team in behind the scene of Pearl Events. Thank you and have a good night.